attending and supporting a great idea, which I hope will bring some sparks who will light new fires all over the world. Today I have the pleasure to talk about Down syndrome, Trisomy 21, and what the neonatologist needs to know about that. Yes, I'm from the western part of Germany, and Down syndrome is, of course, one of our topics there too. We all know what it feels like to be confronted with a baby that looks a little like it might have a Down syndrome, and then you talk to the parents and you do tests and you have a story that repeats many times, and then you have a family history that will develop after that. Of course, today, most of the babies have been diagnosed before birth, and that also includes that they have been born because the parents have decided to get the baby and to take care of the baby. Then we look at all these various symptoms, and very briefly I would like to go over the history. Actually, you're all aware that Langdon Down had discovered that and made the first description, but I think almost one of the more important parts of his work is that he actually took very much care of children that were mentally handicapped, which was not very frequently done in the time when he lived. So he was not only scientifically interested, but he was socially taking care of people who needed it most, which we can admire. Now we have so many progresses, and it's true that even since all of us, we went to university to learn about Down syndrome, so much changed about the diagnosis, and we even have some new types of therapies that I would also like to briefly mention. Yeah, the symptoms. The genetic background and the chromosomal basis of Trisomy 21, of course, is 96% of meiotic non-disjunction in the mother's egg, but there are a few other constellations that cause the same syndrome, like a translocation. There are mosaics, rarely, but possibly, and there's also the possibility of a partial trisomy. Nowadays, we have very good diagnostics that are more rapid than in earlier times, and the gold standard might be a whole genome sequencing or a microarray, which are 100% in sensitivity and specificity. But of course, we can also do a combined first trimester screening and a chromosomal microarray. One thing that might also change diagnostics is that it will be possible to take pictures, upload pictures, and have a result on potential syndromes. Several AI tools are being developed, and this is, of course, an opportunity to make a diagnosis without drawing blood, and also this is a learning system, which means that you can diagnose very, very rare diseases. I'm very much convinced that in the future that will be used much more frequently, and there are various applications that can support clinical workflows. For example, there's the Face2Gene app. Down syndrome is, of course, present in all over the world, but the frequency is not identical in the various areas, and it depends on variables like maternal age, and nowadays very much on prenatal screening, since many of the babies, depending on the type of counseling, many of the babies diagnosed with Down syndrome or Trisomy 21 will not be delivered alive. Which means that some have the impression that that Down syndrome will be extinct within a relatively short time. The survival is very different also depending on where you live. It can vary, or the mean age that the patients reach can vary depending on how what support they get. Now we go through the symptoms. I don't want to go too much into detail because probably you know much of that, but there are various heart defects associated with Down syndrome, and interestingly nowadays they can be linked to particular genetic abnormalities, and so it's not just a physical thing, but it's also a genetic link that we know nowadays. There are hematologic manifestations like the transient myeloproliferative disorder, which has a very good prognosis, but it can also become a leukemia. And the neonatal management includes serial blood cell monitoring and also GATA1 mutation testing, because that is associated with more megakaryopoiesis. We all know the duodenal atresia is one of the most frequent gastrointestinal manifestations, and there's Hirschsprung's disease and also tracheoesophageal fistulas. All of them have also been associated with genetic abnormalities. Of course, the immune system has alterations, and these might be linked to the fact that there are 4 interferon genes on the 21st chromosome, which means that these abnormalities of the immune system are linked to interferons in many cases. The neurodevelopment may be close to some of the symptoms that we have just heard so excellently presented by the previous speaker. This may be a floppy infant, like that. And we may, yes, they may be floppy infants, and that might also make it necessary to distinguish between Prader-Willi and other syndromes that are also associated with muscular hypotonia. Now, there has been some research on how actually the third chromosome of the number 21 chromosome, how that happens, what happens on the genetic basis. And interestingly, it appears that if there's one more chromosome 21, all the genome and the expression of the genes are altered, or genome-wide changes take place. Some of the genes are upregulated, some of the genes are downregulated, and some of them, of course, are not changed. And this appears to be important for the clinical manifestation. Many of the diseases that we treat rely on the lack of some information or a defect in genes, and we try to replace the genes or to correct the genes, like in spinal muscular atrophy. In Down syndrome, however, we have too much of some genes, and of course there is also an option to suppress the surplus and to try to correct these abnormalities that are caused by a triple chromosome 21. And these are new therapeutic approaches. So there are gene dosage effects. If there is too much of one gene, it may have a great influence on the other genes of the other chromosomes. And also, there is a spatial organization of the nucleus that is altered by the third chromosome. On the molecular level, there's an area which is highlighted here, the Q22 and Q21, where there are several genes that appear to be of particular importance. In summary, there are 33 protein-coding genes and microRNA clusters and several long non-coding RNAs on this chromosome. And it seems to come down, and much of the symptoms seem to come down to these 3 genes that are located in this particular area. That means if some genes are more responsible for the symptoms, if we could suppress them or adjust their activity to normal, that might also change the clinical pathway of the clinical development of the baby. On the cellular level, we can see that on the left side, the healthy brain has a nicely adjusted communication of the various cell types in the brain, whereas in trisomy 21, there is a thinner cortex, a reduced whole brain volume, and there are less complex sulci, which are there because there is simply less substance, less neurons, and less axonal projections, and less oligodendrocytes. Nowadays, some of these genes that we have just seen are highly responsible for the clinical development, can be addressed with various types of therapies. And of course, that is still in development, but maybe in some years we may have some medication and may reduce the symptoms. There is the opportunity of precision medicine in trisomy 21 if we have an individual genetic compass of every baby, and that might even make it more appropriate than just a one-size-fits-all therapy. For the clinical treatment, there still remain some very simple and important tests that need to be done that we recommend, and that is echocardiography within the first 28 hours to assess for heart defects. These are all the higher level evidence recommendations. The thyroid function needs to be tested. Of course, there is a hypothyroidism in many cases. The hearing, in particular, because of the mucus that may still be in the middle ear, and the eyes and the blood, and of course the karyotype needs to be detected. Then there are respiratory challenges on various levels, from the nose to the bronchi, and they also need attention. And many of the babies, about 50 to 75% of the patients with Down syndrome will have sleep apnea, which also deteriorates their neurological development and their quality of life. Nutrition is very important when thriving might be poor due to poor drinking, and so we need to support what is needed. And one aspect that is often not looked at very much is the atlantoaxial instability regarding the junction between the vertebrae and the head, the skull, and that needs attention because it can cause pain and also malfunctioning if not addressed appropriately. Depending on the healthcare delivery models in various countries of the world, we can see that the life expectancy varies dramatically. Like in high-income countries, patients with Down syndrome will reach ages of 60 plus, which means at this age 100% will have dementia, because approximately at the age of 40 years, most, or in fact all of the Down syndrome patients develop dementia. Then in sub-Saharan Africa, the age that they reach may only be 10 to 20 years, and of course it often depends on the heart surgery availability or not. Our aim, and that's why I think Akhil has also addressed this topic, is to have a fair distribution of availability of treatment to these patients which can be treated. There are lots of ethical considerations, and I am sometimes very moved by the fact when I'm called to a genetic counseling, I usually bring some pictures and a booklet to inform the patients, the parents, what it is to live with, what it means to live with a child with Down syndrome. But in quite many cases, I don't even get to showing the pictures and explaining how the life would be, because they have made their decision beforehand that they will not have the baby which might be, the law allows to not have the baby, but it also is a loss to society. Yeah, the long-term outcome is mainly decided by the heart and by the dementia. And there are some research priorities, apart from the social responsibility to make treatments available and diagnostics available. And the current hot topics in research are molecular therapies, neurodevelopmental interventions, and also the global health research. The neonatologist needs to know about all the various systems that are affected by Down syndrome. And in summary, we can summarize that Down syndrome has various genetic causes, that the neonatal management requires systematic evaluation, and early intervention should be multidisciplinary, and the prognosis of the development depends very much on the availability of such support to the patients as well as to their parents. Life expectancy has tripled in those countries where it is available, leading to the new problem that virtually all of the patients have dementia at a higher age, and that needs to be addressed by probably medical innovations. With that, I would like to thank you for your attention, and I wish us all a great start and continuation of this endeavor of making Global Newborn Society global. Thanks.
Open for questions. Any questions anyone wants to ask? Yes.
This may be a little bit outside our pediatric and neonatal experience, but one of the curious things about Down syndrome, and it was fascinating with the slide that you were showing about amyloid beta protein being a factor, that they have Alzheimer's disease, and it's in that regard, it identifies amyloid beta protein as being least linked to that. Do you think there's